This is TTT Live. I'm DK Rosta. The Ministry of Health is giving an update on the status of COVID-19 in Trinidad and Tobago. We're bringing you live coverage on TTT, Talk City 91.1 FM, and on Facebook at TTT Live Online. We go now to the Manager of Corporate Communications at the Ministry of Health, Candice Alcantara.
Good morning. Thank you for joining us for another Ministry of Health virtual media conference on the COVID-19 response. Our panelists today are faces that you know well: Dr. Roshan Parashram, Chief Medical Officer; Mr. Ronald Sawyerfat, Chief Executive Officer, the Eastern Regional Health Authority; Professor Christine Carrington, Professor of Molecular Genetics and Virology, and Head of the Department of Preclinical Sciences at the Faculty of Medical Sciences, the University of the West Indies. A mouthful there. I am Candice Alcantara, Manager Corporate Communication for the Ministry of Health, and I will moderate proceedings this morning. We go to Dr. Roshan Parashram for the clinical update.
Hi, good morning. Thank you, Ms. Alcantara. Good morning to Mr. Sawyerfat, Professor Carrington, members of the media, members of the viewing and listening public. If I could have the slide with the clinical update, please. So going into the number of tests done so far, 198,200. Reported in the last 24 hours, we would have had 218 new positives, taking our total up to 26,410. Of those, the recovered patients are 15,911. Total active cases now stand at 9,922. 447 are at hospital at this time. 577 deaths. So I'll break down the hospital figures a little bit further. 447, 144 of those are at the Couva Hospital and Multi-Training Facility, 61 at the Cora Hospital, 48 at the Augustus Long Hospital, at St. Anne's 21, Arima General Hospital 69, New Point Fortin Hospital 73, Scarborough Regional Hospital at Fort King George 29, Scarborough General Hospital Signal Hill 2. In the step-down facilities, which is 164, they are broken down into Claxton Bay Correctional Facility, 2 persons, UA Day Hall 27, UTT Valsine 25, Point Fortin Area Hospital 26, Field Hospital at the Jean Pear Complex 27, Field Hospital at Couva 1, Port of Spain step down at, there's no persons at that facility at this point, Tacarigua Facility 10 persons, and St. James Medical Center 40. The total number of persons vaccinated thus far with the first dose, 118,577, 75 and 88 of those, 75,088 are from the AstraZeneca and 43,489 Sinopharm. Persons receiving their full doses, 1,179. Ms. Alcantara, that brings me to the end of my clinical update for this morning.
Thank you very much, Dr. Parashram. And as we all know, the national COVID-19 vaccination drive continues at a pace, and we see high levels of public uptake. At the forefront of these efforts to get vaccines into arms are the dedicated staff of the regional health authorities. Today we invite Mr. Ronald Sawyerfat, CEO of the Eastern Regional Health Authority, to provide an update of what's happening in his neck of the woods.
Thank you very much, Ms. Alcantara, Dr. Roshan Parashram, our CMO, and of course, Professor Christine Carrington, members of the media, our viewing and listening public, Team RHA, and all healthcare providers. Again, good morning. The RHA, folks, is one of the 5 RHAs in Trinidad and Tobago. Our region geographically covers a 1/3 slice of the island of Trinidad, starting from Matlot in the north down to Guayari in the south, and including the settlements of the north coast. We also have Sangre Grande, Valencia, Cumuto, Corial, Beach, Brothers Road, Rio Claro, Mayaro, Manzanilla, and the associated settlements around these defined areas. Normal population of the ERHA is 130,000. However, in less challenging times, we can double that with the transient inflows on the weekends and public holidays. The ERHA, like our other fellow RHAs in Trinidad, We follow the national program for the COVID-19 vaccination as led by the Ministry of Health. Our vaccination program takes into consideration the widespread area, all right, and the challenging or the challenges associated with a scattered but fairly defined population settlement throughout the region. We have been administering vaccinations at the Toko Health Center, Sangre Grande Enhanced Health Center, all right, which covers the Valencia, Kumutu, and Corial, as well as the North Manzanilla area. The Mayaro Health Facility that takes the South Manzanilla and surroundings, Mayaro and Guayari, and also Rio Claro, where we cover Rio Claro, Beach, Plumita, Brothers Road, and the surrounding areas. We have also managed the mass vaccination site at the Racket Center in Tacarigua on behalf of the Ministry of Health. To date, we have given vaccine doses as follows. Sangre Grande Enhanced Health Center, we have given, and we're dealing with the AstraZeneca vaccines in the early period of April 6th to May 10th. We've put out 2,296 at the Sangre Grande Health Center, Enhanced Health Center. At the Toko Health Center, 843 vaccines, Mayaro 701, Rio Claro 812, and at the Tacarigua Racket Center mass site, we've done 4,945 vaccines so far. The Sinopharm, our first dose, for the 21st of May to the 3rd of June and continuing, we've done 2,443 at Sangre Grande Enhanced Health Center. At Toko, we've done 944, 897 at Mayaro, and 1,349 at Rio Claro, totaling 5,633 doses. In our current drive at Tacarigua Racket Center, we have given 5,089 AstraZeneca doses, and this continues. Total so far, we have done 20,319 vaccine doses throughout the eastern region and our centers. Allow me to highlight that we are in fact seeing a very encouraging sign with increasing vaccination uptake. We currently are doing up to 433 per day, all right, an average at the centers at 433 per day. And before that, we were doing far less than half of that, okay? So that we are seeing an increase in the uptake. The population is more interested now in taking the vaccines, and we are dealing with that uptake. At this point, I would like to indicate our plans and outline our activities for dealing with the second dose rollout. Please listen carefully and note if necessary. The ERHA has embarked upon our part of the national rollout of the second dose AstraZeneca vaccines as of today, June 7th. Second dose sites for AstraZeneca run by the Eastern RHA would be the Tacarigua Racket Center, and at the Tacarigua Racket Center we will be doing the Sangre Grande Enhanced Health Center, as well as those who got their vaccines before at the Tacarigua Racket Center in the previous period. We are doing, and we have about 7,241 doses to administer at the Racket Center for Sangre Grande Enhanced Health Center and the Tacarigua Racket Center. So if you got your first dose at the Enhanced Health Center, your second dose will be done at the Racket Center in Tacarigua. If you got your first dose at Tacarigua Racket Center, your second dose will be done there also. Our next center would be the Mayaro Sporting Complex. We aim to deliver 1,513 second doses there, and those will be for those who got the first dose at Mayaro, District Health Facility and at the Rio Claro Health Facility. All right, so that if you got your first dose at Mayaro or if you got your first dose at Rio Claro, you're now going to the Mayaro Sporting Center where we will administer your second dose. Kumana Outreach Center, we expect to be doing 843 vaccines there, and those are the vaccines for people who have had, our clients who have had their vaccinations at the Toko Health Center in the first wave. So if you did your vaccine, first wave of AstraZeneca, first dose AstraZeneca at Toko, you will now be doing your second dose at the Kumana Outreach Center starting from today. I want to note that you will receive a telephone call confirming the date and time, all right, of your second dose. You are to bring your vaccination card and an identification, valid identification, on the day of your appointment. Note again, if for some reason you miss your call, because we have been having that challenge of unanswered phones and so on, all right, in doing our follow-up calls to let people know. If for some reason you miss your call, please visit your designated center between 8 and 9 weeks, between week 8 and week 9. Don't go under week 8, all right? Between week 8 and week 9 of your first dose, please visit your center if you have not received a call. And I repeat that. If for some reason you miss your call, please visit your designated center between week 8 and week 9 of your first dose. I wish to appeal to our clients also to keep your appointments and the stipulated times, as this will minimize your waiting period and as well enable us to maintain social distancing at our centers. In closing, I wish to thank Team ERHA, our doctors, nurses, EMTs, CSRs, all staff from various departments who continue to work tirelessly to ensure success at our treatment and vaccination sites. I want to say all hands are truly on deck at the ERHA.
Thank you very much.
Candice, let me just say, you know, I have to throw in the 3 W's. I think it's so important. I want to remind everybody, be safe, all right? Wear your masks, wash and sanitize your hands, and watch your social distancing. I add a 4th. Where possible, please remain at home. The ERHA wants to remind you also that caring is the key. Thank you very much.
Thank you very much, CEO. Very important reminders for the public there. And we are all very encouraged as well by the increase in uptake that the ERHA is experiencing for the COVID-19 vaccine. Just to alert the public as well that information about the second dose of the AstraZeneca vaccine in the facilities managed by the Eastern Regional Health Authority, that information is available on their social media pages and on the Ministry of Health social media pages as well. So you can look there and determine which facility you need to go to for your second dose of AstraZeneca. And very important, please walk with valid identification and your immunization card, as the CEO indicated. We go now to Professor Carrington. She continues to keep us up to date on developments related to variants of concern. Today we look at vaccines and variants.
Thank you so much, and good morning to the my fellow members of the panel, and also to everyone out there in Trinidad and Tobago who's listening and watching this morning. So we go back to the beginning. When someone is infected by the COVID-19 virus, what you have is cells within their body producing millions and millions of new copies of the virus that can then go on to infect others. Now, during that replication process of the virus where it's being copied, you can get errors being made, and those errors are called mutations. Now, as a result of that, the virus has been changing or evolving over time. And there are now more than 1,200 slightly different versions, named versions of the virus, which we call lineages. And those can be distinguished from each other based on the mutations that they carry. Now, as we've discussed before, most of these mutations have little or no effect on the virus's ability to cause infection or disease. However, occasionally, you do get mutations arising that can affect the virus's properties. And these SARS-CoV-2 lineages with altered properties, they are sometimes referred to as variants. Some variants are of public health concern because they spread more easily or they're more resistant to treatments or vaccines, so they're referred to as variants of concern. Now, the WHO recommends that countries monitor and track variants of concern and that they carry out surveillance for new variants and share this information openly with the global scientific community so that when significant variants arise or when they're detected, countries may be informed about how best to combat them and to prevent their spread. Now, this type of surveillance can be done by regularly testing for variants in a random selection of community samples using a technique called whole genome sequencing. Now, in addition to monitor potential impacts of the virus evolution on vaccines, on therapeutics, or disease outcome, it is also recommended that whole genome sequencing be performed on samples from specific groups of individuals. For example, people with suspected reinfections, people with prolonged chronic or very severe disease, any vaccine breakthrough cases, etc. And of course, countries are also advised to closely monitor viruses entering their country by sequencing samples from incoming travelers. So at the University of the West Indies, we have been carrying out this type of genomic surveillance on behalf of the Ministry of Health since December 2020. I should emphasize that whole genome sequencing is not the same as PCR testing. PCR testing is used to detect whether a particular virus is present or not. It is whole genome sequencing is a much more complex and time-consuming procedure that is a technique that reveals the detailed structure of the virus's genetic material. And it is the only way to detect and fully characterize new variants and to unambiguously type existing ones. May I have the first slide, please? Right. So this chart here shows all of the different lineages that we have detected in Trinidad and Tobago across 521 samples that were collected from individuals between August 1st, 2020 and the 11th of May, 2021. In all, we have detected 16 lineages of SARS-CoV-2 in Trinidad and Tobago, and their names are shown on the list on the right of the graph, and among them are two variants of concern, B117, first detected in the UK, which the WHO now refers to as the alpha variant, and then P1, which we know we have community spread of, which was first documented in Brazil, which the WHO now refers to as the gamma variant. Now, as shown in the graph, there have, over the past, since August last year, there have been three dominant lineages in Trinidad. We have in turquoise there, we have B1.111, which was most prevalent around August. It is not a variant of concern, and that one we don't see very much of that anymore. Then it was largely replaced by R1, shown in red, which we first detected in cases from about February, and it's also not a variant of concern. And then in April, we had P1 emerging, and that's shown in yellow. P1 now accounts for about 38% of all the sequences that we have generated since December. Now, next slide, please. Right, this graph shows the proportions of different lineages detected each week since the earliest sample in which we found P1. P1 is in yellow, and you can see that the proportion of P1s in the samples that we've been sequencing has increased steadily from week to week. All right, so from the epidemiological week 14 up to 19, you can see the yellow getting larger. It's basically replacing the R1 that was there before. Now, very importantly, since the samples that we sequence were not all randomly selected, the proportions of the different lineages shown here in this graph are not necessarily representative of the general population. However, this picture of rapid expansion of P1 is consistent with observations in other countries, and it is not unexpected. Now, we can take the slides down now, and I'll turn back to vaccines. So one of the concerns about P1 is that it contains a number of mutations in the part of the virus called the spike protein that is a major target for the protective immune response and the protein around which COVID-19 vaccines were designed. However, despite these mutations, despite them affecting how easily antibodies can neutralize P1 and similar variants in laboratory experiments, we now have almost 2,000 million doses of vaccines administered around the world. And what we have is a lot of real-world data indicating that vaccines remain extremely effective against severe disease, hospitalization, and death, even in the face of these variants. For example, in Manaus, Brazil, where the P1 variant was very prevalent, mortality rates among the elderly declined rapidly following the initiation of their vaccination program, which targeted the elderly first, and that was using AstraZeneca and Sinovac vaccines. In another town in Sao Paulo, Brazil, they saw a 95% reduction in deaths, 86% reduction in hospitalization, and an 80% reduction in symptomatic cases for with these vaccines. We currently have the AstraZeneca vaccine and the Sinopharm vaccine, not Sinovac, but Sinopharm and Sinovac are the same type of inactivated whole virus vaccine. So Sinopharm would be expected to perform very similarly to Sinovac. We also have data from the Seychelles, where many of you would have heard that they had a surge in cases despite high levels of vaccination, and that was using AstraZeneca and Sinopharm. Now, a lot was made of this in the press and the headlines, but it is important to remember that infection is not the same as disease. So counting a case, when you count a case, if you have an increase in cases, you don't necessarily have an increase in sick people, because not every person who gets infected gets sick. None of the vaccines that we currently have prevent all infections, but they all reduce your chance of becoming sick if infected. And they're all extremely effective at preventing severe disease, hospitalization, and death. So, in the Seychelles, although they saw infections in some vaccinated people, 80% of the people who were hospitalized were unvaccinated people. And there were 0 deaths among vaccinated people. So the vaccines work. Now, the variant in circulation in the Seychelles was a different one from what we have here. It was B1.351, which is now called the beta variant, and was first identified in South Africa. Interestingly, the mutation that is thought to affect vaccine efficacy in B.1.351 is the same as in P1. And experimental data has shown that P1 is not as resistant to vaccines as B.1.351. So we can reasonably expect the Sinopharm to perform as well against the P1 vaccine. You understand why they changed the names of these variants, because they're quite a mouthful. So the next vaccine we received in Trinidad and Tobago is going to be the Johnson & Johnson vaccine, which is very similar to the AstraZeneca vaccine in terms of the technology that it uses. It's a viral vector vaccine. It too has been found to be very effective at preventing severe disease, hospitalization, and death, and to be effective against different variants. Now, for those who worry about whether the vaccines available to us are good enough to tackle variants, it may be helpful to think of the vaccine as an excellent trainer who trains your immune system to fight a specific opponent. And that is the original SARS-CoV-2 virus that emerged from China. Now, after training, your immune system knows exactly what the opponent looks like and how to defeat them. So when the real fight comes, your immune system can easily beat the opponent. The virus isn't able to land a single punch, and you don't even feel sick. Now imagine that instead of the opponent that you train for, along comes a slightly different opponent, a variant like P1. This is exactly what, this is not exactly the opponent that you train for, that your immune system is trained for, but the variant, and as a result of that, the variant may be able to land a few punches and you might get some symptoms. But the training was good enough, the training you got from the vaccine was good enough to allow you to beat the variant. The variant only causes minor damage, you don't end up in hospital, and of course you don't end up dying. So now consider an unvaccinated person. They have never seen the opponent before, and as we've seen from countless clinical trials and now from real-world results, they are much, much less well prepared to fight. And as a result, they have a much higher chance of ending up with severe disease, being hospitalized, or unfortunately dying. Finally, many people are concerned about the side effects of the vaccine. All vaccines have side effects, but the most common ones are mild, and the severe ones are extremely rare. The chance of severe adverse events with any of the vaccines is thousands of times lower than the chance of severe effects from the virus itself. So, as usual, I urge you to wear your mask properly, watch your distance, wash your hands, stay at home when you're feeling unwell, get tested, and give your immune system a fighting chance. Take the vaccine when it is offered. Thank you.
Thank you very much, Professor Carrington, for those very clear and encouraging reassurances about taking the COVID-19 vaccine when available to you. She encouraged us to give yourself a fighting chance. Thank you, Professor. And we go into the question and answer segment. As you know, we sometimes field questions that arise often from you, members of the public. And today we have two such questions. We begin with the first question. Can I mix COVID-19 vaccines? If I took AstraZeneca, can I take Sinopharm COVID-19 vaccine, for example? And CMO, I think you'll answer this first one.
Yeah, so I think this question has been going around for a while. So what we know so far is that WHO has approved vaccines, meaning that you use the first dose of the same type of vaccine. For example, AstraZeneca you have as a first dose, you give AstraZeneca as a second dose. Sinopharm you get as a first dose, you use it as a second dose. What has been happening in certain territories around the world is possibly because of shortages and of course because of research. They have been using a first dose of one type and a second dose of another type. Now, it is, in terms of early research, it is suggesting that there may be some improvement in the overall efficacy, but it's early days yet. So the national policy of Trinidad and Tobago, as of this time, once you have one vaccine, you have a first dose and a second dose from the same vaccine. So early research ongoing. We will see what that bears, if that bears any fruit as the months and weeks go by. But for now, our policy is first and second dose of the same type of vaccine.
Thank you, CMO. And I think even the second question may fall in your lap. What is the protection rate of the Sinopharm vaccine? What does that mean?
Yeah, so just building on what Professor Carrington would have started in terms of the discussion, different endpoints are given by different vaccine manufacturers. In terms of their trial, the one Sinopharm would have used was the protection from severe disease or death, and their rate is 78.1%. So in 78.1% of the people that take Sinopharm, you get that full range of protection. Having said that, generally speaking, you get milder disease in even beyond that 78.1. So their rate, if you're looking at a rate, is 78.1 protection.
Thank you very much, CMO. And now we open the floor to members of the media to pose questions to our panelists. Members of the media are reminded, please state your name and the name of the media house that you represent before posing no more than 2 brief questions. Of course, if we have additional time, we will come back to you. We begin now with questions from CNC3 of Guardian Media Limited.
Hi, good morning, everyone. Rashad Khan, Guardian Media Limited. My 2 questions this morning are for the Chief Medical Officer. So, Dr. Parasram, on Wednesday, we're going to start more of a walk-in approach to taking COVID-19 vaccine. So I'm just wondering, can you walk us through what it is we can expect, how people should come forward to taking those doses, and how you will plan to avoid large crowds gathering at these vaccination sites? And my second question, Dr. Parasram, is understanding that a a patient has the right to choose their treatment or even refuse treatment or anything or along those lines. Some persons have raised concerns with me that they would prefer to take the AstraZeneca vaccine closer to the 12-week interval as opposed to the 8 weeks, which is what we're trying to do right now. Is any such facility being made for persons who may wish to take that second dose at that longer interval?
Right, so let me answer the second one first. So in terms of that longer interval, as you know, WHO has recommended an 8 to 12-week interval for taking this particular vaccine. The Ministry of Health, considering all epidemiological factors involved, if you notice, we would have had a 12-week time frame when we would have given appointments. That has been brought forward to 8 weeks for reasons being the present status of the epidemic in Trinidad and Tobago. We would like a greater proportion of the people in the country to be vaccinated with both doses at an earlier point in time. It gives us the benefit of protection, full protection, in terms of your second dose, and we think this is the decision that we took as a national level is to bring it forward to 8 weeks. In that regard, your appointment will be given to you by one of the RHAs, and we ask that you please stick to your appointments that are given by the RHAs. In terms of the crowds, we have considered various strategies. The RHAs will be leading it. Again, I'll ask Mr. Soyafat to go into a little bit of detail as to how he has planned with his centers to prevent. One, we will expect to get crowds, which is a good sign that people want to have the vaccine. But of course, we want people to maintain the 3 Ws when they come to the vaccination site. Wear your mask at all times, social distance at all times, and make sure that you follow the rules set out by the healthcare providers at the site. But Mr. Soyafat, I'll ask you just to go into a little more detail for the Eastern Regional Health Authority, what he'll be putting in place to assure that we don't have any events occurring at those sites.
All right. Thank you very much, Dr. Parasram. I think it's important that the public listens. Firstly, the fact is that when we start on Wednesday, we start by having the over 60s doing the walk-ins. So it's not the general population that should be walking into a health center come Wednesday, but the over 60s. And then we follow, of course, with the under 60s with comorbidities and so on in that first time. So that's very important. The other thing is we have to ensure that we do the crowd control. So we have beefed up in terms of our security presence to assist us with crowd control. All right. The local police will be around to help just in case we need some persuasion and so on, which we don't expect. So we expect that people will behave appropriately, will understand that they must maintain their social distancing and they must maintain what is required of them to ensure that we reduce risk in terms of the number of people. So again, I want to point out, one, that we're looking at the over 60s and the under 60s with comorbidities. We're asking that not everybody just descends upon the facility all at the same time, and we ask that people adhere, to those requests. And again, as I said, we will do what we can in terms of our customer service reps and our security services and so on to ensure that we monitor the crowd and try to control that as much as possible. We've also put in different lines. We've beefed up the number of stations available so that we will be able to try to cope with the increase in throughput. So I think that's about it, Candice.
Thank you very much. I think, CMO, you had one other point
to add. Just to clarify, so when we begin on Wednesday, it will be the same phase 1 sort of approach we'll be using, but again, it will be walk-in as opposed to appointment. So we're looking at persons who are over 60, whether you have comorbidities or not, and those who are under 60 with comorbidities, as well as, of course, healthcare workers will be given their vaccine by walk-in from Wednesday.
Okay, great. Thank you. And I believe that only persons who are eligible will be vaccinated. Yes, CEO?
That's right.
Yes, definitely so.
Okay, great. Thank you so much. We go now to Radio Tamrin, please. Are we ready with Radio Tamrin at this point in time? Yes, I see him coming.
Yes, good morning. Clayton Clark, Radio Tamrin. My questions, I think this one is to Dr. Parasram. There are reports that some ambulance service providers are overwhelmed with the number of emergency calls they have had to respond to. One newspaper reported that an average of 200 calls per day. Also, part of the challenge is that there is no dedicated fleet to deal with COVID-19. This is according to the service provider. And some drivers have expressed concern over the payment they receive per call. Each time they respond to an ambulance call, they're saying it's not enough. What have you to say to the ambulance service providers and the drivers on these concerns reports? And second question, a member of the public is asking for an update on the number of migrants reported infected with COVID-19, have died from the virus, and are warded at hospitals across the country. Thank you.
Okay, all right. So with regards to your first question, in Trinidad at least, the GMRTT is the service provider for transfers. I don't know in terms of the actual number of calls that they have been receiving, but what we are following is their transfers, their transfer time, for example, and Dr. Richards would have provided the population with an update, I think, on the Prime Minister's conference on Saturday as to how much time it takes to actually transfer a patient. They have a dedicated fleet, as far as I am aware, to deal with COVID-19 cases, which is separate and apart from their regular ambulances because of infection prevention control issues that may arise. So there is a dedicated fleet, and I think there's an improvement in the turnaround time over the last couple of days in particular with regards to the way they are responding to COVID-19 cases, and of course to other cases as well. But if anything beyond that, we can get a detailed report from the service provider and get back to you. With regards to the second question, I'd like to get a full report on the migrants to date, and we can again get that information back to you. It's not something that we have focused on in terms of our analysis from Dr. Hines, but I'll ask him to have a look at it, and we will get that information to you as well.
Thank you very much. And now questions from Express newspaper, please.
Good morning, Kim Bodram from the Express. Firstly, can we get perhaps more insight into the ministry's analysis of the increased deaths that we've been seeing? And not just in the context of there being increased infections and therefore more deaths, but in terms of what is happening with treatments in HCU and HDU, if possible, maybe a little more breakdown of how many deaths in either of those hospitalization wards. And specifically looking at the treatments being used, yesterday the Express carried a story from quoting a United States-based intensivist, Dr. Karim Razak, and he is suggesting that TNT stop using the drug azithromycin where antibiotic care is needed, because this has been shown to be ineffective and possibly, detrimental to patients. So can we get some more insight into the deaths themselves and the ministry's investigation into that? Also, for some weeks now, we've seen that parts of the commercial sector and recreational sectors that were thought to have been causing increased infections have been mostly shut down, but the numbers don't appear to be declining as quickly as, let's say, the public, from the layman's perspective, would have expected. So can we get further analysis on what the contact tracing is saying about the sources of infections? We did see some of it being in the workplace and the homes coming out in the last week. But can it be that the home self-isolation methods are not working and that people are in fact going home, and similar to what was seen in the early stages of the pandemic in places like Italy, infecting those with comorbidities and the elderly and also causing increased deaths? Thank you.
Ms. Bodram, we will go to CMO to respond, and we want to remind everyone, please keep your questions brief. Sometimes we get a comment with a question. We just want to give as many people a chance to ask a question as possible, okay? We go to CMO now, please.
Yeah, so I don't know. I'll try and start with this second question. Basically, there's no specific treatment that has been approved by WHO for the treatment of COVID-19 to date. And I need people to understand that. So WHO has not approved a treatment for this disease. There are now approved vaccines. There has been a focus about using from the beginning hydroxychloroquine and other drugs. None of them have been approved to date, and Trinidad and Tobago stands by its position that we will not use a specific treatment unless it's approved by WHO. The clinicians using antibiotics in a clinical setting is determined by what they think is the best for any particular, the antibiotics are not used to treat the virus. They are used to treat bacterial infection that may arise as a secondary out of a viral illness. So that will be guided by the clinicians, and they will make the best choice based on what type of infection occurs. In terms of the last question that you had with the epidemiology of that, what was happening, I think Dr. Hines spent quite a long time on Saturday going into that particular issue. And really and truly what we are seeing from his graphs is a beginning of a plateau with a small dip in the number of cases. It is a quite large epidemic in the sense that the number of cases were high. We don't expect that any measures taken will take you from 700 down to 0 in a day. It will take some time, and the population has been consistently following the guidelines and continue to do so. We expect that that curve will continue to move in the direction we want it to move, which is downward, with decreased numbers of daily deaths as well as number of cases. And really that is what we want to see. It is not going to be 700 to 0 over a period of a week. It will take some time.
Thank you very much. And we go now to TV6. 2 brief questions, please.
Hi, good morning to the panel. My 2 quick questions. I know that, well, right now, in terms of many people are asymptomatic, and we've been doing, quite a lot of vaccinations. So I'm wondering, we don't do, is there any, should we be concerned, or should persons who have had the virus and didn't know they had the virus be concerned if they take the vaccine? Are there any health risks in that regard? That's my first question. Second question is in terms of the 7-day rolling average, because we've had a problem in terms of the reporting aspect where you would see samples span over 3 days, 4 days, 5 days. I was wondering if we can get an average as to the daily number of cases being mapped to that to those reporting samples. Thank you.
Okay, so the first question, generally speaking, you're talking about somebody that doesn't know they have COVID-19 and goes for a vaccine. There's nothing in the literature that suggests that there will be complications arising out of someone that would do something like that. Just to remind that the national policy, if you do have COVID, that you wait 3 months post-COVID infection to have your vaccine, both if you have infection after the first dose or prior to the first dose. So the policy is 3 months. However, if you don't know that you are infected and you do have the vaccine, there's no data to suggest that there will be untoward effects at this time. With regards to your rolling average question, we do use the data that is provided daily to create the rolling average. I believe it's just around 370 at this point in time based on the last 7 days, which has decreased significantly since last week. So we do use the daily data as a reported data, not the swab date, to create the rolling average.
Thank you very much, CMO. Now we go to TTT.
Good morning. Terry Ann Brown Campbell from TTT News. I have 2 questions. Some people, 2 persons called in with concerns. One person indicated that it is time for her to receive her vaccine. She went to get it. She was turned away. In a scenario like that, what do you do? I mean, she was told she needs to go home. Her name is not on the list, and she hasn't gotten it. How long do you wait? Who do you approach if you need to address a situation like this? And the second question is another scenario where everybody in the household has COVID-19 except for the minor child. And this person is about to go into hospital, and she finds herself with a minor child, no one to take care of them. Does the ministry have anything in place to deal with this? Is Children's Authority will be addressing it? How are you all dealing with a situation like this? Thank you.
All right, let me take the second one first. So yes, through the Office of the County Medical Officers of Health, we have had cases like that in the past. And what we do is we liaise with the respective ERHA, the Children's Authority if necessary, as well as the other relatives of those children, to see if we can get a resolution to the issue. So we have had cases before, and we do the liaison as necessary through the CMOH. Just some clarity on the first question. Are you talking about someone going with an appointment for their second dose or their first dose?
Yes, she went in to get her second dose. She was told her name is not on the list. She was asked to return home. She's in a quandary. She doesn't know what to do. How does she address this?
Okay. Let me just point out, as I said earlier, if someone has not received a call, all right, scheduling their appointment for their second dose, they must visit the facility between 8th week and 8th and 9th week, and they will be scheduled. We have adopted a policy in the centers also that if a person turns up, okay, once they are within the window of the 8 weeks and beyond, they will be vaccinated even if they are not on the list for that day, right? We will try to assist and do that so that the person doesn't have to go and return. I know, for example, I'm not certain where you're referring to with this case that you're talking about, but I know that someone turned up at one of our centers this morning for a second dose, and in fact, they had not even reached the 8 weeks, and therefore they were told that it's not ready, they're not on the listing yet. The other thing is that that person, should I say, was not even supposed to be vaccinated at that center. They were supposed to be vaccinated at another center. So we need to appeal to the population to listen very carefully, to present at the center where you are supposed to present at to get your vaccine, and to ensure that you don't, out of anxiety or otherwise, turn up within 4 or 5 weeks of having your last shot. You need to adhere to that 8 to 9 week window if you have not received a call, but likely you will receive a call. We are catering, as I said, for those who may not answer the phone or something of the nature when they're called, but please try to adhere to the procedures that we are laid out.
And just to close, if you can send that person's information to us offline, we can arrange for that person to be sorted out.
Yes, Ms. Brown, please send to the Corporate Communications Unit, and we will filter it through to the right parties. We go now to I-95.5, please.
Good morning, Ms. Alcantara. Good morning to everyone on the panel. Whitfield Turner from I-95.5. My first question would be for Professor Carrington. Do you know whether any of the samples that would have tested positive for P1 thus far would have originated in Tobago? And if you can give us some idea as to whether, if in the case of a cluster and one person in that cluster actually has P1, whether other persons in that cluster would also likely be candidates for the P1 variant. And my question to CMO, there's an open letter addressed to you in The Guardian written by Ira Martha entitled Open COVID-19 War Room to the Private Sector. I don't know if you've seen it and if you care to respond. Thank you.
Okay, thank you very much. So no, I can't tell you if any of the P1 samples we have were from Tobago. When we get the samples, they come blind, which is normal for a sort of diagnostic procedure. Well, not diagnostic, but for a type of screening procedure. So I don't have that level of information. If we have to do specific analyses, we can get them, but I don't have it. It doesn't come automatically. We might, for example, say which ERHA it came from or something like that, but I can't tell you right now whether P1 was detected in Tobago. Your other question was whether if one person has P1 and they interact with other people in a cluster, whether those other people will also have P1, and the answer is yes. If I'm infected with a particular variant, that is the variant that I'm going to spread to someone else. Now, every time someone is infected, you do get changes in the virus. So you can, after a successive infections, you can get sort of evolution of the virus away from where it started. So there are sort of sublineages of P1 that would emerge, but it would be P1 for now. It takes longer for that type of change to occur. So yes, this is why we have to look at random samples to be able to work out what's happening in the general population, because if we get, for example, 10 samples and 9 of them are P1, we can't then say 90% of the people in the infections in Trinidad are P1, because those 9 people might have been from the same cluster. Okay, so that's why we have to look at that. Okay, thank you.
Yeah, so I would have read part of the article. So what I think the two main issues addressed in the article is, one, private sector involvement in vaccination programs. And as you would have seen, the Ministry of Health would have sent out an ad actually calling for volunteers to assist in the mass vaccine sites, which includes the private sector. So we have done that, and in the press conference on Saturday, the Prime Minister, Honorable Prime Minister, as well as the Minister, would have gone a lot in the engagements with private sector that is ongoing and that will continue, which of course started with the Supermarkets Association, with the Trinidad and Tobago Manufacturers Association, construction sectors, and various other private sector and entities. So we did get, I'm told we did get a lot of volunteers from the private sector, and we'll be using them in our mass vaccine sites. We have also liaised with the TTMA, our Trinidad and Tobago Medical Association, and Nursing Association to widen our net of human resource that can be used in the mass vaccination sites. The other issue raised, I believe, is that issue of COVID-19 being treated in the private sector. And I just want to say, from the Ministry of Health's perspective, the private sector was never told at any point during this pandemic that they can't see COVID-19 cases. But on the contrary, a lot of the cases, once they turned out positive, were shuttled to the public sector, and we were happy to have them and continue to do so. So there's no restriction on private sector seeing COVID-19 cases from the Ministry of Health, but we will gladly see the cases if they are not seen in the private sector.
Thank you for that clarification, CMO. We go now to AZP News, please.
Hi, good morning.
Hi, good morning.
This is Suan Wire from acpnews.com, and well, one of my questions was just answered, and the other one I have, probably CMO can answer this one. The World Health Organization last week approved another Chinese vaccine, Sinovac. Have you all done any research on this particular vaccine, and will it be considered to be administered to our population, considering the arrangement with the Chinese government that is already in place? Thank you.
So the Sinovac vaccine, I think Professor Carrington would have mentioned the vaccine when she was doing her presentation. Basically, it's a similar vaccine. The efficacy is about 50.6%. Used quite a lot in Brazil. Seems to have protection against the P1 variant. Again, it is WHO approved. Our negotiation so far has focused on the Sinopharm vaccine in that particular company, but I can't say, we can't rule out anything going forward in terms of the type of vaccines that we will use in Trinidad and Tobago. But for now, we are getting the Sinopharm vaccine, and that's the one we're offering to the population of Trinidad and Tobago.
Thank you, CMO. We're coming close to the end of time this morning. Let's get a quick one question, please, from CNC3. Let's get a quick one question, please, from CNC3.
All right, Professor Carrington, I remember earlier on when we now started seeing a rise in COVID-19 cases and the fatalities, that you were doing some sequencing on some of these deaths to see if the P1 variant had any role to play in those fatalities. I'm not sure if you announced it or it came before and I missed it, but just an update on that. Have we seen any fatalities in relation to P1?
Sorry, I don't have that information. As I said, when the samples come to us, they tend to come to us blind. We sequence them, we send back the results to the Ministry of Health, and they have the other part of the data. If we have to do specific investigations, we really liaise with them about that and get additional data. But I can't answer that question.
Thank you. Radio Tambrin, please.
Yes, good morning again. Clayton Clark, Radio Tambrin. A question from a member of the public. I want to find out COVID testing for 2-year-olds and also for those under the age of 13 years. What's the latest on that?
Yeah, so COVID testing, meaning doing a PCR test on a patient to see if they're positive, yes? Yeah, so COVID testing can be done on anyone regardless of age and has been done in Trinidad and Tobago and other parts of the world.
Thank you. And the final question today from TV6, please.
Hi, I was wondering in terms of what would we need, or what would we need if we have to ramp up testing for the P1 variant to give us an idea of to what extent it is truly within the population?
Well, basically we do two things when we do testing of that nature. So one, the first objective I think of Professor Carrington's study was to see what types of variants we had circulating in Trinidad and other parts of the Caribbean, remembering that is a study that is for other parts of the CARICOM region as well. So that was the first objective. In Trinidad, as we continued to sample our cases, and she said over 500 cases, she could go back into her slide if she wishes, but at the end of the day, it is seemingly that the P1 has replaced other variants as the major variant of concern of the major circulating strain in Trinidad and Tobago. And she can go back into her graph if she wishes, Professor Carrington.
Can we get the graph, the second one that I showed? Right, so all right, so if we can get the second graph that I showed. Right, so this sort of, when a variant arises in a particular population, it is the norm for the lineage to expand as it spreads from one person to the next. The same way we have exponential growth of the epidemic, you can get exponential growth of a particular lineage or variant. And you get some of them will expand, they will last for a time, and then they will become extinct as other ones take over. So it's a normal process. And you can see from this graph that since the first week when the earlier sample in which we detected P1, you see the yellow section, that's the proportion of P1 samples. And you can see that it's increasing over time. So it is at the last bar, I think was 11th of May. And you can see that it accounts for 90% of what is out there. So, it accounts for 90%, I should say, of the sequences from the samples that we get. As I said, these samples are not all random samples, so we can't sort of extrapolate directly from this to the population. But I think we can be pretty certain that it has expanded and it is the dominant strain right now. So it's basically it. We just have to continue with the sampling that we're doing, the random sampling, targeted groups, etc., and we'll continue to do the sequencing and get the data out.
Thank you very much, Professor. And just to clarify some information for the public, the upcoming walk-in arrangements are for persons who are 60 years and over, or persons who are under 60 with an NCD. Just to clarify, the walk-in arrangements are for persons 60 years and over, and those under 60 with an NCD, and there are specific locations that this will be facilitated. Please look at the websites and social media pages of the Ministry of Health and all of the regional health authorities for further information. We have come to the end of today's media conference. Thank you everyone for taking part and for playing your role in protecting Trinidad and Tobago from COVID-19. Just today, the Honorable Terence Deyalsingh, Minister of Health, this morning he received his second dose of the AstraZeneca vaccine. We can do this, and we are doing it together. Wear your mask, watch your distance, and wash your hands. Stay home if you don't need to go out. And as soon as your dose of the COVID-19 vaccine is offered to you, please take up the offer. Thank you and be safe.